Please welcome, from the University of Minnesota, Associate Professor of Pediatrics, Dr. Michael Pitt.
Good morning. So we spent a lot of time this week talking about the future of medicine, looking at innovations in medical technology, diagnostics, personalized care, innovative health policy. But there's one area we haven't explored deeply enough yet. And unfortunately, it's an area that if we fail to focus on, will leave the other advancements in the past. I'm talking about medical education, training the future doctors at the front lines of each and every one of the future healthcare scenarios we've discussed about this week. Failing to focus on the need for innovation in this space is dangerous. And I want to take a few minutes, luckily, because the University of Minnesota and the state of Minnesota are at the forefront of this change as well. We can take a few minutes to look at some areas where the need for innovation in medical education can evolve with and set the stage for the future of medicine. So we'll do this looking at three areas. We'll start with what we're teaching in medical schools. What needs to change? We'll focus on the what. We'll transition for the need for improvement in who we are teaching. This is an area we have fallen a little short on, and we'll spend some time looking at that. And then lastly, we'll go to the how. Specifically, I will highlight an innovation that the University of Minnesota is leading the way on in how we train doctors. So let's start with the what. You've heard this already a lot at this meeting. Medical knowledge is doubling at a dizzying pace. The amount of medical knowledge in existence, when they looked in 1900, they thought this might take 150 years to double the amount of knowledge that existed to learn. By 1950, that was down to 50 years. 1960, 10. 2010, 3.5 years, less than the duration of medical school. And it's projected in 2020, you saw in the last presentation as well, to be under 3 months, just over 2 months, before the entire knowledge of medicine doubles. One way to think about this is a medical student who starts medical school this year will have as many as 20 doublings of medical knowledge occur before they graduate. Think about that. So that means that we have to accept that we cannot possibly teach everything. And we have to move from a focus on traditional medical education, which taught us what to know, and shift to teaching providers how to know. And really more importantly, and increasingly popular, how to behave. So let's look at two examples. One is the area of diagnostic error. This is taking the fields of behavioral economics and psychology and empowering providers with a vocabulary and understanding of how human beings make decisions. Having this framework allows us to approach diagnostics with a pause, an ability to realize when we're falling into shortcut traps in how we make diagnoses. I'll say one of the most exciting things that happens on rounds as a pediatrician is when I'll have a resident stop their presentation and say, using these frameworks, you know, I fear we're falling into anchoring bias here, relying too much on the thinking that was done by the emergency room. Let's pause and re-examine what else could be going on. This focus on how we make decisions about diagnosis and increasingly about how we get feedback in real time about our own diagnostic errors is really at the forefront of the future of medical education. One area that I'm excited about is this concept of empathy being a skill. Empathy is a teachable skill that is needed in medicine. It is therapeutic. Unfortunately, most medical providers are good at empathy in the real world, and then we train it out of them. So think about it. If you were my neighbor and you fell off a ladder, and I saw you fall off the ladder, I'd run across the street and say, oh my gosh, are you okay? That looked terrifying. What can I do to help? Can I take you to the hospital? But if I saw you in the hospital, I'd be trained to say, did you hit your head? On a scale of 1 to 10, what pain are you in? I'd probably ask using jargon, did you have any emesis? Why is it that we can be empathetic in the real world, but we've lost it in medicine? Some exciting work that has happened about empathy being therapeutic came out of the University of Wisconsin. They looked at providers that were using just at least one empathy phrase during visits for the common cold. Something that said, oh, this must be difficult. Something that showed empathy rather than just data gathering. And those that had a doctor that had just, in the recordings that they reviewed, had just used one empathy phrase or more, had symptoms less than 1 day longer than those that had no empathy. This would be malpractice if I was not prescribing a medicine that shortened things or using technology to shorten things. I need to start teaching empathy as a skill. Who here has seen the YouTube video where it's called It's Not the Nail? There's a husband and wife on the couch. I'm seeing a lot of nodding. She has a nail sticking out of her forehead. And she says, I've got this crushing headache, honey. It's just terrible. It's right here. It's throbbing. And he goes, like, Sarah, it's the nail in your forehead. She goes, it's not the nail, Jason. Why do you always do this? You always try to fix things. You know, but it's right here. It's throbbing. All my sweaters are snagged. And he finally goes, that must be really difficult. And she goes, it is, thank you. And she leans in and the nail hits their forehead and it starts over again. But the point is, as providers, we tend to be taught to look only for nails. We go into medicine so excited to find the nail. And I've had many conversations with residents and medical students who are feel that the only skill that's needed is to skillfully take out that nail. I'll say, you know, my patients don't care if I'm empathetic. They care whether or not I'm the best person to take that nail out. And I tell them they care about both. They need both. You can be both. You've created a false dichotomy. And this is one of the areas that we're really focusing on, how to behave and treat empathy as a skill. You've heard also at this conference, with that expanding medical knowledge, another focus is how to teach providers to retrieve information. When I was in medical school just 15 years ago, if I heard a patient with a murmur and saw a rash, I had to think first, this might be rheumatic fever. And if I want to diagnose that, let me remember that, first of all, call the librarian, ask him or her to search through, find an article on the diagnostic criteria, send it to me 2 to 3 days later as a stack of papers, dig through and find the criteria to diagnose that. That was the process in my career, and I'm 36 years old. Now, I pull it up on my phone in 1 second, and I have that diagnostic criteria. This is obviously an area to bring clinical decision-making to the bedside and support, allowing us to spend less energy on retrieving and finding information, but rapidly being able to pull it from existing places. My specialty, pediatrics, has realized this. The American Board of Pediatrics knows that providers cannot be expected to know everything anymore. And their board certification test, recertification, rather than being a single test in a room every 5 years, is now sending questions periodically to our smartphones, allowing us to do what we would do in the real world, to look for answers to help us solve those clinical problems via resources that are readily available. They realize that it's time that we do as well in our medical training. So as we think about what stakeholders can think about what's changing, focusing on ways that prioritize the art of medicine and treating empathy as a skill, and pursuing innovation to support clinical decision-making. Much of that we've heard at this conference so far. So let's look at the who. It is well known that medical outcomes are better when patients have access to providers that have had similar experiences to their lives. Unfortunately, we've fallen pretty short on this. We look just in 1980, just 30 years ago, we graduated 4 times as many men as women from medical schools in the United States. This is an area of strength where we, over the last decade, have to see some equalizations there. But take a look at how far we are from that when we look at underrepresented minorities in medicine. Black and Hispanics make up 30% of the population of the United States, but are woefully underrepresented in the providers that we train in medical school. Another concerning thing about this chart is if you total up the amount of graduates from medical schools over the last 30 years, that number is really identical as it was in 1980. You've heard many people talk about the kind of coming tsunami of a medical shortage. And unless we are doing things to train more providers and different type of providers, we will fall short of being able to provide the care our families need. There's an untapped human resource. So one of the things that I've been excited about recently is looking at the role that immigrant and international medical graduates providing medical care in the country. 1 in 3 internal medicine doctors, board-certified internal medicine doctors in the United States, trained outside of the United States. Medical graduates immigrate here after having trained outside of the United States, have to repeat their training, apply for medical school or residency, and repeat their training in the United States to take jobs that U.S. providers don't want to work. Immigrants taking jobs that U.S. citizens don't want to do. Does that sound familiar? I have a colleague who is trained in India and then at the University of Minnesota, and she works now in LA as a pediatrician, seeing 80 patients a day, or 80 plus patients a day, many of whom are children of immigrant farmers. And both the parents of her patients and my friend go home every night wondering if they're welcome in the country that they're working. She told me they were looking to buy a house and start a family, but she's been afraid to do so because her visa, if anything were to change with her work visa, she'd have to leave the country in 30 days. The country that she's provided care for literally tens of thousands of our children. This must change. One of the ways Minnesota is looking to change this is by partnering with the Minnesota Department of Health and the state legislature, a first-in-the-nation program called the International Medical Graduate Assistance Program. This has provided funding to train immigrant international medical graduates, people who have lived in Minnesota for at least 2 years and will commit to working in the underserved part of the state for 5 years after their training to receive an earmarked spot in our residency and specialized training in pediatrics. This has been a really exciting thing. We are in our 3rd year of this program, and I know you've heard about burnout and resilience at this meeting. I'll tell you, I interview candidates for both this position as well as our categorical residency. And I ask a question, tell me about something you've overcome, a challenge you've overcome. This is a marker of resilience, which is a protective factor in burnout. I can tell you I have never had an answer that did not blow me away when interviewing these candidates. One family told me about waking up in Syria to chemical warfare, getting his family in the car, leaving his practice and his home behind, crossing the border to Jordan to be in a refugee camp before getting to the United States years later. I asked that same question a week later to somebody from Michigan. Tell me about a challenge you've overcome recently. And she told me about how they had booked the wrong week for their honeymoon in Barcelona at the hotel and how they had to stay in a hostel for the first 2 nights. So it's a little bit about the who. I want to highlight, again, what can stakeholders do? We can train more doctors and advanced practice providers. We can take steps to reflect the population we treat. And we can leverage existing untapped resources and advocate for those resources that are already here. Let's move into the how. So traditional medical education has followed what's called the Flexner model. This is a fixed amount of time that was defined to determine how long it takes to become a doctor. 4 years, we put you in residency or medical school, we set a timer, and we hope that by the end of that 4 years, you're finished. It's fixed time, variable competency. So to think of that as a baking analogy, that would be putting a cake in the oven, setting a time and never checking on it. Maybe it's gonna come out a little soggy, maybe it's gonna be burnt, maybe some cakes were ready a little early and some needed more time. What we're doing at the University of Minnesota, we are one of 4 programs aiming to flip the Flexner model on its head. So instead of fixed time, variable competency, we're saying, what if we knew exactly what a pediatrician looked like and what it meant to be a pediatrician, and we were constantly evaluating you to constantly check the cake. So we call this education in pediatrics across the continuum, and we have medical students at the end of their first year that are certain they want to do pediatrics, having the opportunity to enter this advanced program where they get frequent evaluation. Their medical school training is tailored towards pediatrics exclusively. And when they are ready, they roll into the residency, not based on what time it is, based on those frequent thermometer checks. How are they doing? The residents that have rolled into this program have typically had over 170 to 300 individual points of direct written and personal feedback. This is where this is going. If we realize the doubling time of medical knowledge, we need to specialize our training and allow people to have personalized training, not just personalized healthcare as patients. So as we think through what we've talked about, 3 things. Again, what can the stakeholders do with how? We can embrace individualized parallel training paths towards competency rather than just fixed time. And then we can also recognize that personalized medicine starts with personalized medical education. So as we reflect on the 3 things we've talked about today, we've talked about what we are teaching in medical school and how we have to accept we can't teach everything, but we can teach how to think, how to behave, and how to retrieve. And it's our job in this room to help support those 3 missions. We've realized that there's room to grow, that we need to treat both create a population of providers that reflect the population we treat, and also meet the demands of our patients with the growing physician shortage. And finally, we've talked about an innovative model of how, focusing instead on the amount of time it takes to graduate, refocusing towards the competency needed to get there. But I hope we've learned a more important lesson along this way. You know, we've acknowledged that there is a breakneck pace to the advancements in medical technology. And it's quite possible that pretty soon I will get an alert on my watch, or we may get alert on our watches in 3 years that say we've got cancer. But I want to train the person, the human resource that will be there to help make the diagnosis make sense, answer questions with empathy, readily retrieve available information, and help me collaboratively create a treatment plan towards my healing. My other goal is that we train those providers that look less and less like me over time and more like the population we treat. That's the future doctor. That's truly personalized medicine that no technology can replace. Thank you.